Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Hi, I'm Dr. Barry Waldman from the Centers for Advanced Orthopaedics in Maryland, DC, and Northern Virginia. So I'm here today with some of our experts talking about some of the technical aspects of joint replacement. We did an episode about who we think is a candidate for joint replacement, some of the preoperative considerations, some of the recovery time, but there's a lot of technical aspects of doing the surgery itself. So as joint replacement specialists, a lot of the time we're seeing patients who have already seen a medical doctor, maybe a rheumatologist, a lot of time even another orthopedic surgeon. And patients are very, very sophisticated nowadays. Sometimes they will come in with a bunch of printouts from the internet about this high, and they'll have a lot of questions about the actual technical aspects of the surgery, and we're happy to talk about them. So one of the first things that I want to talk about is the actual parts. And maybe, Rishi, tell us a little bit about the parts and how you choose them, maybe for a hip replacement or a knee replacement.
They always ask about what parts we use. And the way I counsel patients on that, I tell them it's kind of like a shoe. So whether you buy Adidas or Nike or Reebok or another type of shoe, at the end of the day, it's all a shoe, and it's really what sort of feels comfortable to you and your personal preference. And they're all great. It's not like any one of them is bad per se, and they all function well. It really comes down to a preference thing. And it's the same thing with the parts. In terms of the actual implants themselves, for a knee replacement, there are four major pieces that we're putting in. There's the femoral component, which is made of some sort of metal. Now again, each company will have different alloys of different metals, and they'll say, oh, our metal is better because it has this, that, or the other. So it's, whether it's cobalt chrome or titanium or oxinium or what have you, there's different types of metals, but it's, at the end of the day, it's a metal implant that's on the femur. There's a metal implant that's on the tibia. And the femur is the thigh bone, the tibia is the shin bone, just to clarify. And then there's a plastic liner that's in between. And then behind the patella, now this is a little bit controversial. Some people will resurface the patella on every patient. Other surgeons are more inclined to just resurface the patella if it's worn out. But again, that's just a technical piece. So it's 3 or 4, I guess, is the way I should say it. Pieces that will go into a total knee. Now this plastic, it's not like your grocery store plastic. It's highly engineered plastic that's gone through rigorous testing and a lot of evolution actually over the years. Plastic used to be, a type of material that would wear out, and that's when people got this idea that, your implant's only going to last 10 years or less or what have you. But over time, this plastic has really undergone a lot of change, and they're putting different stuff in it, like vitamin E or what have you, that really increases the longevity of the plastic. So that's what's giving these implants longer longevity, because the engineering that has gone into it. So the same thing for a hip. There's the hip is a ball and socket joint, so there's the cup. So the cup is typically metal. There's a stem. So the stem is what sits inside the marrow space, inside the femur. And again, those are the two metal pieces. And then there's a head ball that sits on top of the stem. And the head ball, there's a couple of different, again, implant manufacturer specific. There's different alloys that are used or different things that are used, but typically ceramic or some sort of metal. And then there's a plastic liner that goes inside the cup. So it's that plastic liner, again, it's the plastic that starts to wear thin over time. That's what gives the longevity to an implant. So it's really the plastic that's come such a long way, in addition to nuances with the implants, but the plastic has really come a long way to increase the longevity of these implants.
So it's interesting that that you mentioned the different manufacturers, and of course there are many large manufacturers in the United States and around the world that make joint replacements. And one thing we found through research is that if you have a surgeon who does a large number of joint replacements, and you have a hospital or a surgery center that does a large number of joint replacements, that's far more influential than the actual parts that are used. So while these parts are all very, very high quality, the research would show that the important thing is to have a really high volume surgeon and a really high volume hospital or surgery center because they have the expertise, they know how to prevent complications, and they know how to really start a rapid recovery. So Dr. Anvari, in ancient times, maybe when I was a resident, we cemented all of these parts in place. We still do some of that, but what implants, what patients do you find you would use cement, not use cement? How do you feel about that?
Sure. Yeah, that's a great question. I think there's more variability on the knee side, so I'll leave that for now. On the hip side, it's the gold standard used to be a hybrid total hip replacement, which was a cemented femoral stem and a non-cemented cup, and now the gold standard has become a non-cemented femoral stem and a non-cemented cup. The exception being very poor bone quality, such as you would find in typically someone with osteoporosis, which typically tends to be an elderly female. In practice, I'm always prepared to go either route, but usually from x-rays, you can tell what the expected bone quality will be. And for the most part, I'd say probably 95% of my hip replacements are non-cemented. The advantage that gives is that if you get a biologic bond between the bone and the implant, because the non-cemented implants are porous and they're designed for bone ultimately to grow onto them, so you get a biologic fixation between the bone and the implant. That is shown to last longer and have less risk of loosening with time, and therefore less risk of needing a redo surgery or revision surgery. So that's really a great advancement. And as you mentioned, there's multiple companies that make good porous non-cemented implants, and which implant you choose to use really depends on what you're most comfortable with. There is a preoperative planning or templating process that most of us go through where we can sometimes calibrate the x-rays ahead of time and determine what sizes of parts and shapes we're going to use. And there are different angle and sort of technical elements where we can adjust angles and lengths to really fine-tune and custom fit the implant to the patient's particular anatomy. Whether you're making up for a leg length discrepancy, oftentimes the arthritic hip is a shortened hip, so you can determine how much length you want to make up and other nuances.
So yeah, the fixation has changed a great deal over time, and our parts have gotten much more durable and tend to last much longer than they did decades ago. Research would show that only about 6% of patients ever need their joint redone, which is a wonderful statistic. So 94% of patients have one operation and it lasts them the rest of their lives, which is really gratifying to us. I just want to briefly mention shoulder replacements. So shoulder replacements are very similar to a hip in that they have a ball and socket, and many of them are done in an uncemented fashion. In other words, the bone grows into the metal. Until I would say about 10 years ago, one of the biggest problems with shoulder replacements was we didn't have a good way to make up for the rotator cuff. The rotator cuff are muscles that control the ball and the socket kind of staying in place, and without the rotator cuff, the ball would just kind of come out of place and the shoulder wouldn't move very well. So recently we've introduced what's called a reverse shoulder replacement. And what this does is it literally reverses the ball and the socket. So the ball goes on the socket side, the socket goes on the ball side, and that sounds kind of crazy. What it does is it allows the remaining muscles to have a lever arm to move the new joint. So even without a rotator cuff, patients with a reverse shoulder replacement can actually lift their arm up and get it high up, often above their heads, and restore a lot of the motion that we couldn't restore in the past. So it's really been a great advance, and we've been very gratified to see how well our patients are doing. Another thing that's actually been much more common recently is different approaches for the hip. So by approach, we mean how do we actually cut the skin, how do we move the muscles out of the way, how do we put the parts in place? And there's really been, I'd say, a revolution over the last 10 or 15 years in how we approach hips. So Dr. Gupta, why don't you tell us a little bit about what your approach is for hips, how you actually position the patient, do the surgery, what have you changed recently?
The way I trained, or the way that I've chosen to do my hips, is I do an anterior approach. So the way that a lot of patients come in sort of asking about it, they ask, doc, do you go from the front or the back? And really it boils down to, the historic way, the way that a lot of joint replacements were done in the past was via what's called the posterior approach. Now, what is the posterior approach? Basically, it's an approach that goes through certain muscle layers in the back of the hip. It goes through a lot of the glute muscles in the back of the hip in order to access the joint. The difference between an anterior approach and the posterior approach is instead of cutting through muscles to access the joint, you're actually spreading between muscle layers. So it's actually a nice way to get in because there's very little disruption of the patient's native anatomy. And you still get access to do everything that you need to do. So, in terms of how we actually position the patients, a lot of patients come in, they're like, do you use the table? And you're asleep before you get on the table, and the table is very highly technical and well designed. So when we get you on there, your body is safely positioned on there. But what the table allows is for us to manipulate your leg so that we can get the exposure we need. We can get the bones into the place that they need to be so that we can get the implants in appropriately. Now, there are people who are doing the same approach, the anterior approach, without a table. And it's not to say that one is better than the other. It's a training thing. It's sort of how you like to do things. It's not going to necessarily affect your overall recovery. And really, sort of just to take a step back on anterior versus posterior, if you have a posterior approach hip, it's not like you're going to do badly. It's not like a posterior approach hip means that, oh my God, my muscles are forever torn and I'm going to do worse than a person who has an anterior approach. Really, what the research has shown is that those patients, whether they've had an anterior or posterior approach, at 3 months, all those patients are doing relatively similar. So what the anterior approach sort of says that it does is that it makes the recovery just a little bit quicker. So again, patients come in and they ask, well, can I get an anterior approach? And I would say that in my practice, the vast majority of my patients I am doing an anterior approach on, but there are certain patients that come in that you really shouldn't do an anterior approach on. And who are those patients? It's patients that have a large roll from their stomach that's hanging over that skin. And sometimes those patients, the skin isn't very well taken care of in that fold. So when you look at where you're potentially going to make that incision, that skin isn't the healthiest looking. And those patients, you say, we should probably use a different approach on you. And then, patients with significant deformity or things that the anterior approach, while it's really nice and allows for that quicker recovery and has some benefits, on the flip side, sometimes it's a little harder to get really great exposure to do some of the more technical, difficult procedures on. So if you have a patient that comes in that's a little bit more challenging, that has a little bit more deformity, that you're just a little bit worried that, look, I'm going to need to get more exposure, do more for this patient. You want, those patients you're going to choose to do. I choose to do a posterior approach. Now, what's the other approach that's typically used is the interlateral. And so the interlateral approach is somewhere in between the posterior and the anterior approaches. And it's still cutting through some muscle. Again, those muscles are repaired in the end. At 3 months, all the patients are doing similar. So again, there's nothing that's necessarily better or worse about, at 3 months between any of the approaches. It's just a different way of how you've accessed the hip.
The approach can be very important, and as Dr. Gupta said, not everybody's a perfect candidate for any particular approach, and there are a lot of patients where an anterior approach is a great idea. There are some patients where a posterior or an anterolateral approach is a great idea. And the important thing is for us to kind of stratify people. We don't want to have any complications. We're always keeping in mind the fact that patients need these joints for decades, and if they get better in 4 weeks or 5 weeks or 7 weeks, in the long run, we want that to be as safe as possible. And talking about safety, talking about how to get people through the surgery, one of the trends we've seen nowadays is to have a shorter and shorter hospital stay, to the point where many of us can now do joint replacements as an outpatient, even in a surgery center. And many of those patients are actually in the surgery center for as short as 6 or 7 hours or even shorter. So Dr. Anvari, how do you approach this? How do you feel about outpatient versus inpatient? What's your practice now?
Outpatient surgery has only sort of become possible due to the improvements in multiple areas, due to the improvements certainly in surgical technique, with minimally invasive techniques, tissue sparing techniques that don't cut unnecessarily, and so patients have less pain afterwards and can recover faster, but also advances in anesthesia with the spinal anesthetics, regional blocks, intraoperative injections that reduce postoperative pain, and better blood control techniques with, again, combination surgical technique and use of tranexamic acid. It has become possible to do this in an outpatient setting. Now, whom you decide to do this as an outpatient really gets into proper patient selection. Typically, I choose patients that are motivated. They tend to skew to be a bit younger. They don't want to be in the hospital overnight. The assumption, though, is that they're capable physically and from a pain management standpoint. So if a patient is young enough, healthy enough, strong enough, motivated, then that's someone I'll choose to do it in the outpatient setting.
Do you feel there's a safety difference between an outpatient setting versus the hospital?
If you're choosing the right patient, there shouldn't be. So a patient who has had a heart attack, who has kidney disease, liver disease, more elderly, less strong, I think it is a little safer to do in the hospital, where you have the safety net, if you will, of to keep them overnight, monitor their heart, check their labs the next day. But it's been very well shown that for those who are not medically at risk, as long as you are well trained and have a good team, both surgically and anesthesia-wise, that you can do it very safely outpatient.
I'm amazed at how happy my patients are being at home, being in their own bed, doing their own therapy. I can't think of a patient who was had an outpatient procedure, went home, and said to me, "Gee, I wish I'd been in the hospital."
Right.
Very rare that ever happens. So Dr. Gupta, you did a fellowship on robotic surgery, and this is something that has become more prevalent the last couple of years. So tell us, what is robotic surgery? Do you have R2-D2 there, or what is your robot?
So the question that often comes up is, so if I'm going to have this done robotically, are you going to be there? Of course I'm going to be there. It's not like there's some droid that's standing in the operating room that's like doing the surgery and doing everything. Really, these are just tools. It's another instrument that's in the room that helps guide your surgery. So what do the robots actually do? A lot of the way that these robots are designed is that you get images of the patient's particular body part before surgery, whether it's a knee or a hip. Those images are uploaded into their computer. And then their computer generates a very detailed image of the patient's individual anatomy. So then you can preoperative plan, you can decide, look, this is the implant that's going to fit perfectly, this is where I want it to sit, these are the perfect angles, so on and so forth, so then when you get into surgery, what you do is that you register the robot to the patient. So then, and essentially what that's doing is making sure that the robot knows where this patient's specific anatomy is in space. So that there's typically pins that are put into the bone that register to the robot, so that the robot, whether the leg moves in one direction or the other, or the patient moves in one direction or the other, the robot still knows exactly where the patient's anatomy is. And then once the patient's registered, then what the robot does, there's different robots that are out there. So what one particular robot does is that it can actually, it uses a burr, but there's also, so essentially what it is that you bring this robot arm in and it has haptics. So haptics are that it keeps the tool within a certain area. And then the surgeon is guiding the robot to make the specific cuts within that specific area. And the robot has all of this programmed into its system, so it knows exactly where the cuts need to be made, so it gets a more precise cut of exactly what you want. If something doesn't register right, or something just doesn't seem right while you're there, you can always override and say, look, this isn't right, and just go back to your standard way of doing things. But the robot, again, is registered to the patient, and it helps guide the cut. So the surgeon is always in control of making sure that the robot arm is making the cuts in the appropriate area and at the appropriate depth, so that you get the implants in the way that you want it. So what they say is that these robots help reduce the margin of error. So if so that you're more likely to get the implants in the ideal manner. How much of a difference does that make? There is some research to show that, if you get the implants in properly, they are going to last longer. But then the flip side to that is, how much of a difference does the robot actually make? So there's a lot of research to show that if you have a high volume surgeon that's doing a lot of these, the likelihood that the robot's going to make that much of a difference in terms of implant placement is very minimal. And the difference in outcome is very minimal as well. The patients, it's not necessarily that a patient who's had a robotic knee is going to do better than a patient who's had a knee with standard implants or standard instruments. But it can, if you're worried about a particular patient or what have you, it can certainly help guide you. And these days, I'm using the robot more for my particularly difficult patients, where I had one patient that needed a total knee but had a rod that was all the way down, from a prior hip replacement. The rod was all the way down their shaft, and one of the instruments we use the shaft of the inside part of the femur to help guide placement. But I couldn't do that because this patient had a rod in there. So in that case, I was like, the robot will be very helpful. So again, if there's select cases where the robot is actually very helpful, but I wouldn't say that I use it in every case by any means.
So there's certainly a lot of exciting technologies out there, and we're always adding new features, trying to improve the surgery, trying to make it a little better. Dr. Anvari, are there technologies that you're excited about now or in the future, or something we didn't touch on that you think is going to make a difference in your practice?
Oh yeah, I mean, I think all of us like technology to some degree. We're mechanically inclined and interested in the research and the direction it's going, where we can hopefully, with more research, make what are already very successful surgeries even more successful. I absolutely echo Dr. Gupta's experience with the robotics and navigation. I went through a several-year phase of my career where I only did navigated and robotic knees, and now I just do it selectively in patients who I think have unusual deformity, where they're more likely to, with standard instrumentation, fall outside the acceptable range of alignment. So as far as future technologies that I think are exciting, I tell my patients who ask, it's usually a longer than I wish for discussion when it comes to robotics, but I tell them that robotics is very exciting for the future. In its current iteration, it's not that exciting. I mean, it's what future technologies will build upon, but my opinion is that we're in robotics version 3.0, and where will be the inflection point where a robotically performed knee replacement is truly superior from an outcome standpoint and patient satisfaction standpoint, it's probably going to be in robot 8.0. And that will probably implement some measure of artificial intelligence, where right now human brain is capable of juggling only so many variables and manipulating them and considering them at the time of surgery. Much of its experience, much of its feel. Whereas with AI, you can take a grid of 100 variables into account and have a plan where you take the patient's every patient factor you can think of: age, gender, occupation, preoperative gait analysis, strength analysis, range of motion, ligament tension, many variables that we don't even know how to properly measure now. One day you'll be able to input that, and then the robot, the AI and the robot will tell you this is the optimal approach and technique. We're far from that. On the material side, I think evolution in plastics continues, evolution in bearing surfaces.
When it comes down to it, the thing that we all care about the most is our patients, and that they do well, and that they have a good recovery, and that their joint replacement lasts for a really long time. And we may change our approach slightly from patient to patient because that might be the best thing for that individual patient. But in the end, that's the only thing we really care about is that the surgery comes out really well and that our patients are real happy. Having said that, thank you so much for listening to our discussion today. Dr. Rishi Gupta is in Frederick, Maryland, and Dr. Michael Anvari is in Arundel County, Maryland. I'm in Baltimore County, and we'd love to talk to you about any of these things more in person or in the future. Thanks again for listening from the Centers for Advanced Orthopaedics.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.